Okay, so welcome to Bone and Beauty. I'm Dr. Perry Gdalevitch. I'm doing this one on my own, so Dr. Marie Gdalevitch is off today. I actually have the honor and pleasure of having our first ever guest on the podcast, and that's Dr. Jean-Paul Brutus. So I'm going to tell you a little bit about him, and then I'm going to ask him so many questions it's going to make your head go dizzy. So Dr. Brutus, I met him when I was a resident. I had the honor of working with him when he was a staff in an academic practice, but he is basically a hand surgeon who went from an academic career to a private practice career, which is an unusual thing for a hand surgeon, especially in Canada. And he has, I would say, the most successful private hand surgery practice in Canada. He founded Exception MD, which really the goals of that were to promote exceptional patient care. And he has written on that topic a lot. He's also an entrepreneur and most recently like a novelist, like a fiction novelist, which is just like blow my mind. Amazing.
Mine too.
Yeah.
Mine too.
Yeah, it's just crazy. I mean, I didn't know that about you at all when I was your resident. You're also a pioneer of minimally invasive surgery, and you're quite vocal about physician wellness and also the state of the healthcare system in Quebec. So lots of things that I want to ask and discuss, but hello.
Thank you for having me.
Yeah, thank you so much for agreeing to this. I know you're busy, and I didn't know that you live now a little bit further away, so this was an effort for you to be here today. So
It's my pleasure.
Okay, so I'm going to start with just a couple of questions about kind of very briefly your journey into medicine, your journey into surgery. I think, is it your father was also a physician?
Yes, he was a physician. He was a psychiatrist.
Okay.
That can help explain some things.
Yes, your different angles on medicine. Yeah.
Right.
But so other than your father's influence, what brought you to medicine?
Actually, I come from a family of physicians. So, being in medicine is often a family-born disease. Mm-hmm. So on both sides of my family, I had physicians.
Okay.
And
you grew up in Belgium?
I grew up in Belgium, yeah, but I grew up partly in Canada too because my dad and I, and my mom obviously, lived in Kingston, Ontario for a couple of years. And unfortunately, my parents divorced when I was about 4 years old, so my mom moved back to Belgium with me, and my dad stayed here. So ever since, I've been traveling back and forth between the two countries.
So 2 lives, 2 locations.
Yeah, 2 lives, two universes, completely different, especially in those days. And then growing up, I would spend my summers with my dad in Abitibi-Témiscamingue, if you can believe that. And the rest of the year was in Brussels, the capital of Europe.
So he was a psychiatrist in Abitibi-Témiscamingue?
That's right.
Oh my gosh, okay.
That's right. Yeah, he went from Ontario to Abitibi because he liked, peace and quiet and, hunting and fishing and all those things.
Okay.
And so when I grew up, I would spend about the 2 months a year with my dad, and he was very influential, even though it was only 2 months out of the year. And one of the things he said to me was, "Don't go into medicine."
Okay.
And I never knew whether he actually meant it or he was playing mind tricks on me to get me to go into medicine.
Reverse psychology.
Reverse psychology as a psychiatrist. But then, it took me years to realize that actually he meant it. Mm. This being said, I went into medicine anyways, probably because of the family illness. And because of my desire to help people, and that's what got me into medicine.
And then how surgery, and why hand surgery?
So surgery because I wanted immediate results. Initially I considered psychiatry for a little bit until I saw my first and only psychiatric emergency in a hospital. It was scary. It was a man running naked in the emergency department, and we had to run after him to catch him, to sedate him, and so I was like, okay, this is not for me. So I wanted, I'm a very pragmatic person. I need to see immediate results. So I chose surgery for that reason. Very early you see when you meet medical students whether they have the character, the type of personality for surgery or for, internal medicine or other specialties. And for me, it was clear it was going to be surgery. Then I came across, through the different rotations I did, I came across a hand surgeon who I admired as a person, and he was passionate about hands. And he basically infected me with his passion. He passed it on to me. And I realized, hands are unbelievable tools that we use every day to do everything that we need to do, feed ourselves, get dressed, work, and whatnot. But we also, but hands are also incredible means of communicating emotion. Mm-hmm. So when we
Maybe why my sister loves Italy so much.
yes, they use their hands a lot. So when you want to comfort somebody, what do you use? You use your hands.
For connection, yeah.
When you want to greet somebody, at least in the West, what do? We shake hands. When we get married, what do? We ask for the hand in marriage, and then we put a ring on it. So I realized that hands are everywhere, and hands are really a point of access to people's emotions, and that fascinated me. And then obviously the complexity of the hand, the technical side, and you combine it all together, and that's what drew me to hand surgery.
Okay, so but when I knew you, and you were probably the only person I enjoyed watching doing hand surgery, because I am like the plastic surgeon who hates hand surgery.
I didn't know that.
But you were an academic surgeon, and you were a teacher, and you were a researcher, and all of those things. And I do remember some comments along the time that I spent with you about your dissatisfaction with how things were managed at the hospital and patient care not being to the level that you wanted it to be. But talk to us about, this was like a really brave thing to do, to leave academic hand surgery practice. I don't know any other plastic surgeons in Canada who have done this at the time that you did it. And then decide that based on the fact that you wanted to provide more exceptional patient care, that you were going to do this in a private setting. How did you take that decision?
That was a difficult one. It goes back to 2010. So this is 16 years ago now. And I like to say that for big changes that require a lot of courage, either those changes are driven by inspiration or desperation. And I like to say that for me it was inspiration, but it wasn't. It was desperation. I became desperate because of the environment in which I was practicing medicine. And I was struggling, as every hospital doctor struggles in Quebec and probably Canada as well. But then one day I asked myself a very difficult question. And the question was, would I want to be my own patient under my care in my hospital? And it took a while to answer the question, and then the answer came to me, and it was a very painful one. It was no. And because the answer was no, I could no longer stay, because then I would be in conflict with my own values, and that was the trigger for me to leave. Now, why did I even consider leaving academic practice, which was my goal? This was my life dream. This is what I wanted. Why did I decide to go private? That comes from the fact that I've worked and practiced medicine in 3 different countries. So Belgium, that has a combined private-public system. Then I worked in the U.S., in New York, and also has, private and public and
everything in between. Yeah.
Everything in between, exactly. And so and then I came to Montreal and worked in Quebec for a long time.
But there was no model for what you decided to do.
There was no model here.
Yeah.
And so I learned from the best of what I could find in Belgium and the best I could find in the U.S. And I decided, you know what? Maybe there's a way to create something here that allows me to deliver the standard of care that I would want to receive. It was as basic as that. And I always wondered, how come my colleagues here in Quebec or Canada, how come they didn't do it? And then it took me a while, but I realized that because they don't have the same perspective that I have, and that perspective came from just simply working in different countries, so different cultures.
Knowing that it's possible.
Knowing that it's possible, and that you can create something that doesn't exist. You don't have to be bound by the existing reality.
It takes a certain personality and entrepreneurship type of leadership, because I think doctors are extremely risk averse in general, and that was a big personal risk that you took.
It was a big personal risk, but I didn't see it that way at the time, because to me the greater risk was to stay.
Yeah.
I was concerned.
So how did that start out? What were the first few years like? How did you?
Well, I was concerned about who I was going to become if I stayed.
Yes.
So that price to me I wasn't willing to pay. So then I said, I'm going to leave, and if at the end of 1 year, because everybody told me I was nuts.
Yeah. I'm sure.
People told me, you're crazy, it's not going to work, blah, blah, blah. And I said...
I'm sure they all thought you'd just end up doing like Botox and boobs and whatever. Yeah.
Yes, which I could have.
Yeah.
But I just didn't want to do that. So I said to myself, after a year, if it doesn't work out, I'll go back to the US or I'll go back to Belgium.
Right.
So I had options, but it worked out. And so the first year was challenging. And one of the reasons it was challenging is not what you think it is. Financially, it worked quite well, better than I thought. No, it was more, I was used to working 80 hours a week. And now all of a sudden,
Yes, you didn't have to work 80 hours a week.
no. And I didn't have 80 patients in a day. You know, at the beginning, I had 5. And I was like, oh my God, what am I going to do with all this time?
Yeah.
And so it took time for me to get
Adapt.
accustomed to this new rhythm. But the most important part to me was that back in 2010, when I realized I needed to leave, there was a physical component that I didn't talk about yet, but I felt sick. And I really believed that I had an ulcer. But then I realized my symptoms would go away on Saturday afternoon to return Monday morning. So I realized, okay, this is work environment. This is not medicine. I really thought I didn't like my job anymore. And it was very, very difficult for me because I had trained for about 15 years. So if you train for something for 15 years and you realize that you don't like it anymore.
Yeah, it's so demoralizing. It's also
completely.
a huge part of our identity. Yeah.
It's a huge part of the identity. And so when I left, I felt an immense sense of relief. So I knew it was the right path, even if it was scary, even if it was uncertain.
Uncertain.
And like you said, doctors by nature are risk avert, and we're trained to minimize risk for our patients.
For
So
sure. Yeah, then
this
it translates
is who
into
we
our
are,
personality.
right?
Yeah.
It's not we're not daredevils.
Yeah.
And you don't want your doctor to be a daredevil
No, of course
anyway.
not. Yeah.
But then,
So do you feel like there, like, you know, when I left, the part that there's certain things that I missed. Is there anything that you feel like you gave up on in order to go this route?
Yes. Unfortunately, I had to give up certain, procedures or certain cases that I enjoyed doing that was just not feasible in the private sector because it's too immature for that. You know, unlike other countries where you can do
Everything.
pretty much everything privately as well, and there's private insurance to help people pay for care. Here, it's not the case. So I had to give up stuff. I also had to give up teaching residents and medical students.
You don't have any that come to your private center?
Well, that's interesting because I've had many. Not at the beginning, but over time, when they heard, they came. And sadly, they had to come incognito.
Yes. We're still the black lights. It's still
because they wouldn't get permission from their academic center to be able to come.
Yeah.
So they would contact me and say,
Can I come anyways? Yeah.
And can we keep it under wraps? And I said, of course you can come. Yeah. And so I've had many medical students, many residents. I've had, obviously, physicians and surgeons from all over, Quebec, Canada, and internationally to see what we're doing and how come we're successful at doing that in a different setting. And also had a lot of therapists, hand therapists, physios, all sorts of people. So every week I had somebody in the operating room with me.
That's nice. So that part is nice.
Yeah, so the training came back.
Yeah.
It's interesting. I had to leave the education system, and then the education system came back.
Which is actually often the case, to be honest. Yeah. Okay, so that's going. So I mean, I had a similar experience with the public system, which is unfortunate. But you're saying that you actually ended up having some extra time to yourself, and is that what was the kind of the driver for your starting to write? Because you didn't start by writing fiction. You started writing things about patient care. You started writing things about minimally invasive surgery, things that were more on point with your career. But is it because you had the time, or what was the impetus for starting to write?
Well, first, I've always written, but for the academic part of my practice, I was writing scientific papers, and that was all about outcomes and statistics and results and this and that, numbers, hard data. But then when I left the academic practice, I still had the desire to write, but I wanted to write about stuff that I was passionate about. And of course, I'm passionate about hand surgery, but I've written enough about hand surgery. I wanted to write about what it is for a patient to go through surgery and how that affects doctors and the interaction between the experience. And so I started writing about patient experience and how we can make it better, and how I learned from many other industries, because patient experience is not taught in medical school.
No.
So
No, in Quebec, you're just lucky to have a doctor. Yeah.
exactly.
Yeah.
So I learned from the hospitality industry. I learned from the entertainment industry. I learned from the spa wellness industry, and basically the restaurant industry. And I sort of learned from each and applied the principles that they set forth in the practice of medicine. And so by working on elevating the patient experience, I elevated my own experience, because in the end, it's a human experience. So I had a lot more fun practicing medicine. I got to be creative in medicine, because in medicine, as you know, there's not much room for creativity.
No.
We have to follow, guidelines and procedures and
Evidence-bound,
algorithms,
yeah.
evidence-based and all that. But when you focus on the experience, which is basically how to influence someone's feelings, emotions, and making them feel better.
Well, this is where I feel like this is your psychiatry background.
That it may be, but this is what really medicine is all about, if we think about it.
Yeah.
Because
But it's different though than like hospitality or restaurant. Like it's not. I mean, I don't see the relationship as being a client based. I feel like a patient doctor relationship is different, or
Yes.
in a certain way.
Yes.
So what do you like? So this is actually quite unique to talk about the patient's experience and elevating the patient's experience. I mean, it sounds like you've drawn on other fields, but this is a different. It's still different.
it's a different type of relationship, and it's very unique relationships.
Yeah.
It's a great privilege to be a doctor, because people come to you wherever they come from all backgrounds, and they're basically naked in front of you. They're telling you, "I'm scared, I'm afraid, I'm in
Vulnerable.
pain,
Yeah.
I'm suffering," and that's a great privilege to have somebody open up to you without having known them for a while, because it happens very
Yeah,
quickly.
instantaneously. Yeah.
And so, with this great vulnerability that is given to you, I think comes great responsibility. And I think that responsibility is to do everything that we can to make that person feel better. And the way
Not
to,
just physically.
not just physically. So, because at the end of the day, I think that's what medicine is all about. We are all often thought of as healers, but we're not really healers. The healing happens in spite of us.
Correct.
We are just along for the ride. So we are here to advise, we're here to give our opinion, but we're also here to accompany the patient,
Yeah, to guide.
to guide them through their own healing, because they're doing the healing. Nature's doing the healing. We're not.
Yeah.
If I cut someone open, I'm just basically cutting them open, but I don't heal anything.
No,
the
that's
healing
true.
happens after, right? So if you think about it, even a physician who accompanies a dying patient, there's not much healing happening there.
Nope.
Maybe spiritually, maybe emotionally, but not physically, right?
The healing of acceptance, I guess. Yeah.
The healing of acceptance, and sometimes being present for the patient, just being, there,
Supportive, yeah.
is all the healing they need. And so that got me thinking about the role of the doctor. The doctor is to, I think, help people feel better.
Yeah.
And
So I find that so amazing, because when I think of hand surgery, I don't think of.
No.
Yeah. But that goes back to your first point, where you're saying that the hands is the essence of human connection.
that's right.
Yeah.
If I was on my dying bed,
Yeah. You hold your hand. Yeah.
I want somebody to hold my hand.
But so let's talk about that first book, because the first book was called Healing Hands, correct? Helping Hands.
The first book was yes.
But that's a different thing. That was like a more this was like your philanthropic side of you. Like this was charity.
And this was a photography book. So I didn't know I had a passion for photography. I had no idea. It just came.
I mean, one of your many talents, yes.
It just came to me. And so basically it was, the book was called Helping Hands, Tendre la main in French. And it basically was pictures, original pictures made for the book of the hands of Quebec celebrities that were involved in helping charities. So in order to be in the book, by invitation, you had to be involved. You had to be a known face, and you had to be involved in making life better for others. So there were about 40 celebrities that accepted the challenge to be in there. And then I recruited about 15 photographers. They were professional photographer artists. And so they would basically take photos of the hands of the person and then a photo of the picture of the face. But then when you open the book, you see the hands first, and with a quote that was chosen by the personality. And then you would sort of guess, oh, who are these hands, And then you would turn the page, and then you would see the person. So that book was sold out actually, and all the proceeds went to a mental health foundation called Les Impatients. And so this is back in 2010, 2011, and so mental health was speaking to me already then.
So let's talk about that, because that's definitely something that I see that you're quite vocal on online.
Yes.
I think something that you've probably felt yourself when you left the public system. But why do you think that physicians, because the numbers are staggering,
Yes.
the average physician today is leaving the practice of medicine at 48 or 49. I mean,
Yes.
that's... like after so much training to say that, like, I'm almost there, like, and then to know like that over, close to 50% of physicians feel like they are already burnt out, but they continue practicing because they feel like they have no they're stuck in this financial loop where they've got all these obligations. Like, what is it? And I don't think it's unique to Quebec, but I do think that we have a lot that we need to work on in Quebec. But
Yes.
what is your perspective? What do you think is really driving the burnout in physicians?
So that's a complex question, obviously, but yes, that's something that is close to my heart. I went through 2 episodes of what I would call burnout in my life, and as a good doctor, I kept working anyways, for a number of reasons, not just financial, but other reasons as well. So first, I think the term burnout gets thrown around a lot.
Yeah, it's awful.
It's because it sort of puts the blame on the person, and if we think about it. Do you know where it comes from, the word burnout? No. So the word burnout was coined by a New York psychologist back in 1974.
Okay.
And he was basically describing a condition that he was seeing in, guess what? Healthcare workers. And he saw those healthcare workers lose their juice, physical, emotional, spiritual, and whatnot, because they couldn't do their job. For reasons that were outside of their control. So that's where the word burnout comes from. Then it got adapted later. But I don't think we're candles, so we don't burn out.
No.
We run out of juice. And why do we run out of juice? Oh, by the way, what struck the psychologist the most, the one in New York, was that the ones that were most affected by what he called burnout were the ones that cared the most.
Yeah, I believe that 100%.
So in other words, the less engaged, the less empathetic suffered less than the more empathetic.
100%.
So...
But I think the burnout continues to stick because we haven't yet found a word to replace it. I'm not sure what that word should be, but
I think a word or 2 words that I think speak better to describe what it is moral injury. And moral injury is 2 words that most people don't really understand or know, but basically it's what happens when someone who cares knows what to do. They know what needs done. They have the skills or the ability to do it.
But something is preventing them.
But something is preventing them from doing it.
Yeah.
And this doesn't just happen once. It happens over
yeah.
and over and over again. And that creates tremendous suffering.
Yeah.
That builds up, and eventually something gives. Unfortunately, doctors they're really good at recognizing suffering in other people because we're selected and then trained for that. But they're not good at recognizing their own symptoms, I'm going to say.
Yeah, but it's also, I feel like that part is also like, there's no space for that. Like, nobody wants to hear about doctors suffering.
No, nobody wants to hear about it.
And, if you actually feel like you're suffering and you want to get mental help, there's like a lot of bias against that, even in medicine itself.
Absolutely. There's a lot of obstacles. But there's no question that a healthy doctor is a better doctor.
100%.
And care delivered by a healthy doctor is better than a care delivered by somebody who's depressed or burnt, right? And yet, you're right, there's so many obstacles for doctors to seek help when they need it. The first obstacle is you have to recognize that you're not doing well. But if you've been taught your entire life to
Just
ignore,
keep working. Yeah.
yeah, exactly, ignore your own feelings and your emotions, ignore hunger.
Yeah. No. What is the phrase that I've heard the most in my residency? This too shall pass. Just
Yes,
trudge along.
keep going.
Yeah.
So, so if you've never been, I mean, you've been trained to ignore what it is that you're feeling, and you have been trained to put the needs of the other person, your patient, above yours, always, which is completely counterproductive. I'm not saying that the patient's needs are not important,
Yep.
but they do not come before yours. Because if you do that,
Yeah.
you're going to burn.
Yeah.
And this is what's happening.
Yeah.
So, and then there are other obstacles. Medicine has a culture of perfectionism and cultivates excellence. But excellence does not mean no mistakes. It doesn't mean no flaws. But yet these two get conflated. So asking for help or saying I'm not okay is considered to be weakness, when actually recognizing your own need
Is a strength.
is a strength. It's not
protective,
weakness. It's the opposite. It's protective. So that's an issue. Obviously, and there's guilt, because there's no secret.
There's guilt. There's loneliness because you don't think other people are feeling this.
You don't think people are feeling that, and you're afraid of increasing the load for your colleagues if you had to, take time off or reduce your hours or and whatnot. So there's guilt, there's shaming, there's and there's fear.
Yeah.
And
I mean, every year on the college application that you have to renew your thing, it asks you if you have mental health issues.
And this is new. It's been for a couple of years now.
Yeah.
And
Which is just crazy to me that you would have to disclose that as a physician.
It's crazy to me too. And again, there's a lot of lack of transparency, because what happens if you say yes to that question?
We don't know.
You don't know.
No. So that it's fear. It's like you're like afraid to be, yeah. And like, I feel like it's actually like, so I actually have a professional coach now, but if I needed therapy, she was like, well, we'll just call it professional coaching.
Of course.
Yeah.
And
which is just ridiculous. Like,
it's ridiculous. And a lot of doctors actually get psychological help under other labels, or they do it under aliases.
Yeah, which is just crazy. Again, just continuing to reiterate to doctors that it's not okay to be not okay.
It's not okay to not be okay. Yeah. And my dream, one of them, is that we create an environment where healthcare is delivered. Because I really don't like the word healthcare system, because system dehumanizes what it actually is. So I prefer to use the word environment of healthcare. Where was I going with this?
That where healthcare is delivered. Yeah.
I would like for the fact that you're recognizing that you may need help, whatever the reason, by the way, is seen as a sign of professionalism, not a sign of weakness. Because it is. And if we compare with other industries, such as, for example, the airline industry, imagine that, say, Air Canada or Air Transat, imagine there was a survey and we found that 50% of pilots are depressed or emotionally distraught, are on medication, antidepressants.
How good would you feel about boarding a plane? Yeah.
Well, they'd be grounded.
Yeah, for sure.
For sure.
Yeah.
Because it's a safety hazard. Imagine a company like, I don't know, Bombardier, or if they had a plant where 50% of the staff, workers, were reporting work-related emotional distress.
Yeah, I mean, there'd be an investigation.
There'd be an investigation.
Yeah.
The CNSST would be all over it, right?
So why is it that we don't have any of those protections?
Well, I think one of the major differences between, say, physicians and other health workers, because the other health workers are also suffering.
Yes.
We know that, right?
Yes.
Nurses.
Yes. No, this is not physician
it's not
inclusive.
just physicians.
Yeah.
But there's something unique about the physician. Number one, the liability and the responsibility lies with the physician. So that's one.
And individually, I find that part difficult. Like the liability and responsibility lie on the physician individually. Like even when you're supposedly part of a group,
Absolutely.
like, yeah. So, and that is like, for me, That's the part that I find could easily be changed.
It could easily be changed.
Yeah.
So what's unique about doctors in Quebec, and more likely in Canada as well, but let's talk about Quebec that I know really well, is that even though 95%, if not more, of doctors have only one paying officer, which is RAMQ, basically government, they're not employees.
Right. They're independent
considered
workers. Yeah.
independent workers, self-employed. And so as self-employed workers, they have no protection that any regular employee gets. So in a hospital,
Which includes things like maternity leave,
mat leaves,
yeah,
pat leaves, sick leave.
retirement planning, all the rest of it.
Exactly. But also human resources. So if a worker has an issue in a hospital, they can always go to HR and report, okay, there's this going on, this, da, da, da.
Yeah, we don't have any of those mechanisms.
There's regulation,
Yeah.
when it comes to how many hours you can work and whatnot. When it comes to physicians, once you are no longer a resident, that's all gone. And I think that's an issue. Because there's no protection, but there's no monitoring.
Yeah, there's no mechanism by which
No mechanism
any
to make
reporting can
sure-
happen, or any kind of
No. So,
or
and-
any
and-
way to actually get a sense of what is happening in the workforce of physicians.
right.
Yeah.
So I think that needs to find change also. And I'm sure there are many ways to do this, but we can't just keep ignoring it.
No. No, because then what happens is we have physician suicide, which you're also very vocal about. And I wanted to give you an opportunity to touch on, because I know it's something that's dear to your heart. And we've recently experienced in our community a significant loss with a pediatrician who committed suicide, and who did kind of sound the alarm. Like she sounded the alarm and said, I'm not doing okay. Like what's happening in Quebec is affecting me, and nothing was available to her to help her.
Nothing, and it ended badly. Sadly,
And she's not just one. Like that's the issue.
she's not just one.
Yeah.
And so when we talk about physician suicide, obviously we're talking about the tip of the iceberg, because yes, suicide is spectacular. It draws attention. But it's a symptom.
Yes.
It's a symptom of everything we've been describing before. Now, often people say, oh, but the person who committed suicide, they had mental health issues, as if it was a discrediting factor.
Yeah, like that explains it. So,
Well, yes, nobody in their right mind commits suicide, because we have this thing called survival instinct that's very, very powerful. So you're going to take your life only because you strongly believe that there's no other way to get out of suffering.
you're stuck.
You're stuck. And that's it. It's overwhelming. You can't do anything about it. That's why you take your
And
life.
you're hopeless. Like there's no
Your
hope.
hopelessness, exactly. But of course, there's an underlying mental health issue, because otherwise you wouldn't be there. So some people will say, oh yeah, but the mental health issue is a personal condition.
Yeah, no.
Well, that may be true in some cases, because guess what? Doctors are human beings, and we're not immune to the mental health conditions that affect the
Like
general
my sister says,
population.
everybody has a mental health issue.
We all do.
We all do.
We all do. We're not all suicidal.
No.
But we all have dark thoughts, by the way. We don't always act upon them, but we have thoughts that we're not, that we're not prefer we didn't have. But we're not immune to bipolar disorder. We're not not immune to depression. We're not immune to ADHD and what else. So just like the population, we have those conditions too, because we're human. The issue is when you take somebody with a vulnerability, let's call it that, and you put them in a toxic environment, then things are going to go really bad. So that's for the people who say, suicide is the result of a mental health condition that has nothing to do with work. No, it has to do with work. Either it is made worse by work, or it is caused by work. And there's a lot of doctors who take their lives because of work. And that
is because they feel that responsibility, or that hopelessness of not being able to live or act in line with their values.
Exactly.
Yeah.
When, you went to medical school, I went to medical school, you know how hard that is. And you know how hard it is before you get in. and you know how hard it is when you're in.
Well, you know how hard it is before you get in. You think you know how hard it is before
No, but I
you
mean
get in.
what you
Yeah.
have to do in order to get in.
Yes, yes, yeah.
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 And then when you're in medical school, and then residency, that's really hard. And one thing that you need to be to survive it is resilient. So doctors don't need to be taught how to be resilient
No, actually, the studies have shown that we are the most resilient.
by nature, by selection, by training. Okay.
Which is why there was that recent article that really angered me. I don't know if you saw it, but there was an article, I think it was in the New England Journal of Medicine, that was describing exactly that physicians are leaving at 48, 49. And the commentary on that in the newspapers and the press was, well, maybe we should be selecting people that are more resilient to go into medicine. And
Good,
that was
good luck finding those.
exactly there.
Yeah,
It doesn't exist. That kind of person does not.
It's basically like if you said to a Navy SEAL, you need to be more resilient.
Yeah, yeah, impossible.
It's
Exactly.
not going to happen.
Yeah.
Because they're human beings.
But again, it's just like that societal instinct to blame physicians.
Yes. And that's also, I mean, this has been going on for years in Quebec, more so than other provinces in Canada.
Correct.
A lot more, actually.
Why is that?
I think resentment towards doctors has been instrumentalized
Politically.
by government
Because they think we make a lot of money.
because they think we make it a lot of money, but they forget that the way we make money is by working a lot. Because doctors
They're
are
paid
not
by the
paid.
act, yeah.
They're not paid they're not paid a salary.
No.
They're paid per act. And believe it or not, the amount that they're paid per act
Is
is actually
ridiculous.
quite low.
Yeah.
So the only reason they make money is by working a lot. But they don't say that,
No.
right? Actually, the media and the government likes to talk about physicians' salaries.
As
When
if we're
there's no-
salaried, yeah.
There's no such thing.
Yeah.
There's no such thing.
Yeah. Misnomer. Yeah.
Yeah,
We're
there
not
is no
salaried.
physician salary.
Yeah.
Not here.
No.
So, so the media and the government. So the government likes, well, the government recognizes that the healthcare environment has been failing for decades, and this is not the responsibility of I mean, it is the responsibility, but it's not the
Sole responsibility.
sole responsibility of the current government.
No.
It's
This is decades.
this
yeah.
is decades of neglect and
And
not doing the right things.
mismanagement of funds and
And all of that, yeah. And then it's easy to find a scapegoat. And the doctors
But it's
are
so,
an easy
that's the
scapegoat.
part that drives me crazy. It's so counterproductive. Like, look at this last round of negotiations with doctors. In the end, the doctors had to stand their ground because and in the end, there was a negotiation that happened. And in the end, all that happened with all of this scapegoating on doctors is that we lost physicians.
And we lost a lot of physicians.
And we lost a lot of physicians. So how was that productive? Like, how did the scapegoating of physicians, like, how many times do they have to make this mistake for a politician to realize, like, it's not, it doesn't work to scapegoat physicians?
It doesn't work except short term.
Very short term.
Because very short term there are gains. Because unfortunately the population, when you repeat a lie over and over and over
Yeah,
again,
it's like marketing.
people start believing it. And then for a few weeks, maybe a couple months, I'm not sure exactly, the population believed.
Yeah, not for long, though.
Not for too long, because it started changing. But I remember and there was a beautiful thing that I actually have never seen before in my life, when doctors got together and rented out the Bell Center out of their own funds, by the way, right?
Yeah, nobody paid for that.
Nobody paid for that.
Yeah.
Nobody else but themselves. And they all got together to basically send a signal of unity. I felt that was a pivotal moment because the population started to listen and realized that no, doctors are not money hungry people, because guess what? You don't go into medicine if your goal is to make money.
Nope.
Okay. You'll make much more money investing the same amount of time and same energy
any
in
other
doing
industry.
anything. You'll make more money than medicine, believe me. So the doctors are not money hungry, they are resource hungry. And they're hungry for resources because they have no resources
To take care of patients.
to take care of patients. It's not resources for themselves.
Nope.
It's to do their job. It's like, imagine a soldier that you would send to war, literally war,
With no gun,
with
no
no
armor.
guns, no weapons, no bullets. And then the soldier would have to fight not the enemy, fight its own government so that they get the resources to do their job.
So
And-
that brings us to healthcare in Quebec, which, I went back and did an MBA, and my thesis was about healthcare systems. And we are the only country in the world that doesn't have a well-developed private sector. And we have this mentality in Canada and in Quebec that the private is the devil.
Yes. And yet our leaders, our government leaders, go private for healthcare.
For sure they do. Yeah.
I know.
Yeah.
I personally know.
Yeah.
So,
But what is it going to take for Canada to understand that healthcare is expensive, that mismanaging funds the way they're doing is never going to cover the population that we needed, that people need preventative care to prevent problems? Like what is it going to take for the healthcare system to change?
telling the truth. And telling the truth is not something politicians do.
No.
Because it doesn't get elected. And there's part of the population that doesn't want to hear the truth.
No. Yeah,
Right?
people are very stuck on this public universal hair. Even some doctors, though. I actually
Even some doctors.
surprised to know that there's a lot of physicians who are anti-private care, which again, it just feels like it's brainwashing through their
It is
education
brainwashing.
system.
That's right. And they don't understand what private care means.
Correct. They think it's cash out of pocket, where really
Right.
the best countries that do this well have insurances and
Absolutely.
yeah.
Canada, Cuba, North Korea are the ones that have this public monopoly.
Yeah.
Is that the
But in Cuba, you can have private healthcare. In Canada, you can't. Like you don't have a private hospital here, whereas in Cuba, you can.
But I don't know if you can for Cubans or
Not
if
for
it's
Cuba, maybe for foreigners.
For
correct.
foreigners.
Okay.
But if you look at the best, say the best 10 healthcare environments in the world, Taiwan, South Korea, the Netherlands, Switzerland are among the tops.
Mm-hmm.
They all have a combination of, universal healthcare does not mean monopoly.
Right.
It means nobody should go bankrupt to get care,
But there should be access to care.
but there should be access to care for everyone.
Because right now, what I consider in Canada is not universal because
Absolutely
nobody
not.
has access to care.
Absolutely. And we know that the access is not the same everywhere.
Right.
And that's one of the definitions of universal. It's supposed to be the same for everyone everywhere. We know it's not the case. If you live in Chibougamau or Montreal or elsewhere, you don't have the same access to medicine in general.
So what if you were the health minister? Because I would love to see you do that. What would you change like tomorrow? What are the 3 things you think you could change tomorrow that would improve access to care in Quebec?
I would definitely learn from the 5 or 6 best healthcare systems in the world, and I would see what the commonalities are. And I would apply them here.
Yeah, I mean that just seems to me like why does Quebec have to reinvent the wheel? They just keep trying to reinvent the wheel. We don't have to create a new system. There are systems that work. There is no perfect system,
That's right.
but there are systems that work much
Yes.
better than what we have right now.
And we can incorporate changes that respect our values and our ways of doing things. But we have to stop digging the hole. And that's rule number 1. When you find yourself in your hole, stop digging. And we keep digging. So, of course, private insurance is required.
Yeah,
I have 3 cats and a dog, and they have private insurance.
but it's also like it's hypocritical to say that because we have private insurance for medication, we have
Yes.
private insurance for dentistry, we have private
Yes.
insurance for eye care. If you want to get
Physio.
physio,
Yeah.
so it's like we're already doing that. We
We
just
al-
refuse to do it for a family physician and a preventative care model, which
And what is a valid reason for that?
There
is
that's what I
none.
don't understand.
There is none.
Yeah, where is this divide? Like, who decided that this is okay and this is not?
I don't have the answer to that because I don't understand it. It doesn't make sense to me, and it's against all evidence.
But that seems to me like the simplest thing to do: expand what is covered by insurance to family preventative care. I mean, tomorrow morning
So-
everybody has a family doctor.
So I think you touched something really important: prevention. We invest almost nothing in prevention. And by the way, we don't do it in our roads either.
No.
In
Or
our
in our schools, in our education,
hospitals,
in our
or
justice system.
so this is a mentality issue. This is a culture issue.
It's reactive. We're not proactive.
We're reactive. We're not proactive. But we could decide to become proactive right now. Not that hard, I think. So I would learn from the best healthcare systems in the world. I would invest massively in prevention. And I would also make people responsible for their own care. People need to play a bigger role in decisions they are making for their own care. We need to help them do that, but they need to do it. I'm not a big fan of Big Brother knows better for everyone. I believe in small government, not big government.
I agree.
Because unfortunately, big governments show how incompetent they are.
Yep.
And you and I appreciate the compliment when you said you'd like to see me run to be health minister, but nothing qualifies me to be a health minister more than thinking and having life experience.
Well, the fact that you have integrity.
Yes, but what I'm trying to say is that we tend to think. Oh, I mean, I've been guilty of this. I thought people in governments were smart people.
Yeah. No.
No. Sadly, I've realized that they're. And I also thought that.
I mean, that is one of the problems, is that we don't have smart people going into politics. Like, smart people are going into business. They're going into the private sector.
Yes,
Yeah.
yes, sadly.
Yeah.
And I also believed that the government told the truth. And we've come to realize over the years that no, they don't.
No. Well, there is no real truth.
There is no real truth.
There's always a different
but there's
Yes.
something that's closer to facts, and then there's
yes,
you know.
politicized. Yeah.
So prevention is massive, and I think we should invest massively in prevention. So that'd be the.
And then in terms of how we can help physicians from a healthcare environment, what would you think that we could try and invest in as solutions?
Well, first, I mean that's a long discussion, but physicians are team leaders. They need to have teams, and a lot of the work can be delegated to people who are qualified to do it that are not physician. I think physicians need to move from the one that sort of does everything, so to speak.
I do everything myself. Yeah.
Yeah, I do everything myself. Also because the liability is on me exclusively, pretty much. I'm the captain of a team, and I'm going to train that team, and that team is going to do what they do. We need to move in that direction, and so for the last few years, I've heard of super nurses or infirmières praticiennes,
Clinician, yeah.
but there's not enough.
No.
And I don't know if they're trained well enough to do a lot of different things. There's none in hand surgery, I can tell you that.
Right.
In the States, they have physician assistants. I work there, so I know. And physician assistants, believe it or not, exist in Canada too.
Just not in Quebec.
Just not in Quebec. They exist in the armed forces. So in the armed forces in Quebec, you have physician's assistants, but not
Interesting.
in
I didn't know that.
Why?
Yeah.
I think that's a change I would have made a long time ago. It'd be cheaper too,
For sure. 100%.
by the way,
Yeah.
and more effective. So, and also, like I said earlier, we need to change the culture of medicine and the culture in general also to promote a culture of excellence. And unfortunately, I don't know what happened in Quebec, but we seem to be obsessed by equity. And I'm not saying equity is wrong. I think equity is great. Equity means equal opportunity to everyone. That's what it means.
Yeah.
Equal access. But
syndicated workers don't give you equality. I mean, it doesn't give you equity.
What I'm trying to say is that you have equity and then you have excellence. But if everybody's equal, then you have no excellence. So I think we need to get to a point where there's a culture change to promote excellence, to promote doing better.
Yeah, but that's for me. That's where also the model fails in the sense that, doctors are independent workers, but everybody else in the healthcare environment is syndicated.
Yes.
And so that there's a disconnect there because performance is no longer valued.
It's actually devalued.
Devalued.
It's devalued.
And the reality is today is any high performing industry, you go to any other industry, other than construction or whatever, but you don't need syndicates anymore because the jobs that are offering the best conditions get the best talent. Like you attract talent based on conditions. It's no longer, we don't live in the post-industrial revolution world where we need syndicates.
Exactly. And they tend to justify their own existence by...
For sure. It's a multi-million-dollar industry in and of itself. So
Exactly. Yeah. So basically it sustains itself.
Yeah.
And
it applies political pressure.
Applies political pressure. And like any organism, it wants to grow. Mm-hmm. So it needs to feed to get bigger, bigger, more influential. And it basically becomes harmful. Because they were very helpful when we had a strong need for them. That's why they were born. Yeah. But then today, I'm sure there's balance in the force anymore. Yeah. So we need to rebalance all that. Yeah. Which is going to be a...
But that I think is probably true in most of Canada. I don't know that anybody has moved away from syndicated nurses and other healthcare workers, but definitely in other countries they don't syndicate everybody. Okay, but I guess then that my next question is the thing that I think is going to disrupt medicine next is going to be AI.
Yes.
And I would love to hear your thoughts on how you see AI affecting medicine. Are you optimistic? Are you worried? What do you think AI is going to change?
About it. I'm optimistic because AI is going to allow physicians who use it, and they'll have no choice but to use it, to perform even better, faster, and increase access to help more people. I think it will also empower people themselves because when people use AI, they can figure out what's wrong with them even before they see the doctor. Of course, AI is not perfect, but it's pretty darn better than having nothing. And it's also even much better than Google.
Agreed.
Because Google got you, a lot of things.
But there are a lot of physicians who are very skeptical about introducing AI into medicine. What do you say to them?
I think skepticism is good.
Yeah.
It means caution.
Good.
But it doesn't mean no. You can't stop water. So AI is here already. I use it every day.
Yeah, what do you use it for?
Oh, I use it to improve my notes. I improve sometimes to do research when I'm not sure about something. I use it to better my writing. I use it for everything.
Just like everybody else.
Just like everybody else. It's a tool. It's like a phone. Everybody has a phone, and we all use our phone to make our lives better and life better for others.
Yeah.
AI is the same.
Yeah.
Now, are there dangers with AI? Of course. And do we need to address those? Of course. But it doesn't mean we need to be scared of it to the point that we don't want to use it and want to shut it down, et cetera,
my
et cetera.
my only fear about AI is that doctors need to get on board and we should be the ones leading how AI is going to affect medicine because if it's going to come from administration, there may be some things that we don't like.
Guaranteed.
Yeah.
Okay. Or industry.
Yeah.
Or industry, absolutely. So my concern is, when my dad told me don't go into medicine, he had a very good idea of what my career was going to look like, sort of.
Okay.
Why? Because, of course, there's change from generation to generation, but not that much. Which is why we can do things father and son or father and daughter, et cetera, because, from one generation to the next, the changes are not that massive.
Really? I feel like medicine has changed a lot.
It has changed, but in essence, being a doctor is this, and this is how you do medicine. There's some changes, obviously, from back. My dad was, a 40-year-old physician compared to when I was a 40-year-old physician. Things have changed, but you still stitch the wound the same way. The principles of healing were the same, and
I feel like there was more respect for the practice of medicine.
There definitely was. But what I'm trying to say is that I don't have kids, but if I did, and I had, say, an 18-year-old child who was saying to me, Dad, I'm thinking of going to medicine. What do you think my career is going to look like? Today, I would say, I have no idea, son or daughter. I don't know. Because of AI. AI,
It's going to disrupt things.
It's going to disrupt everything beyond my comprehension. Think the first
Life
time,
in general.
Yes. The first time I used ChatGPT was about, what, 3-4 years ago? I still remember it. So what is medicine going to look like in 10 years? I have no clue. So people say, yeah, if you're a radiologist, you're screwed. But if you are a surgeon, you're okay. I'm not so sure about that.
I'm not so sure either.
Things change and fast. So we don't know. So no, but how are we going to prepare the doctors of 10 years from now today? We know medical schools are very slow to change, like universities, like academia, very slow, very resistant to change. So how are we preparing today's youngsters for the reality of their practice in 10 years?
We're not.
We're not, because we don't know.
We don't know.
And that's scary. But with any change, you can freeze, you can flee, or you can move
adapt.
forward, embrace it,
And adapt,
and go with it and adapt, and be excited about it. I'm excited about what's coming.
I agree.
Because I think optimism is a choice. I'm not a natural optimist. I choose to be optimistic.
I don't know. As surgeons, you think of worst case scenario
Yes.
all the time. It's not
Yes.
natural to be optimistic.
It's not natural to be optimistic, but I choose to be an optimist because I think optimists actually end up changing the world. When people who are fear-driven usually don't affect it positively.
Yeah,
That's what
I
I
agree.
think. So
So let's get back to beyond medicine, because I do think that having passion projects, and for you, it's more than just a passion project. You're an actual novelist, and this really blew my mind when I read your first fiction novel. I'm a big fiction fan, but you've gone from writing nonfiction to fiction. So I want
Yeah.
people to know that you wrote The Helping Hands, which we talked about. Then you wrote about elevating patient experience. You wrote 2 books about that, book 1 and book 2.
Yeah.
Then you wrote Secrets and Lies from the Operating Room, which was also not fiction. It was a little more of a twist on reality. But then Silent Oath came out, and that is fiction. It's based on some real things
Yes.
and some real issues that you've identified with college complaints and all of that. But it's a fiction book. And so how do you go from going from writing research to books that are relevant to your practice, then to writing fiction? How do you do that?
I don't know how I did it. What I do know is that I never thought that I would be writing novels and thrillers. I never thought I would be doing that. This is not something that was a dream of mine. And when I slowed down my surgical practice, I made, by choice, because I wanted to make room in life
For other things.
for other things, and I just didn't know what the other things would be. And I tried to figure out, what is my life going to look like after I retire from surgery. And I couldn't come up with an answer because I was just too busy thinking of what I'm doing, and I was just too spinning
the
the
motions,
wheel,
yeah.
spinning the wheel. So I said, you know what? I'm not going to figure it out. I'm just going to do it, and we'll see what happens. And that's when things happened. I had an idea that popped in my head, and that's what led to Silent Oath. When I started writing the book, I had no idea how the book was going to end.
Interesting.
I learned later to do it differently. But that first book, I just started writing, and I would allow the story to go wherever it needed to go. But I knew what I wanted the reader to get out of it. So it's a fiction, but it's reality based. So it's based on things.
I identified with that character so strongly. Yeah.
And I chose Sarah. Her name is a successful female thoracic surgeon in Montreal, and she has a family. She has a husband, 2 kids, and she lives in Montreal, and she works in a university hospital in Montreal, and she's a leading thoracic surgeon. She's able to balance life, or she thinks she's balancing life. She's a great doctor. She's caring. She's, top of the class.
She's basically got all of the things in place for a burnout.
Yes. Everything's in place for a burnout, but she doesn't know it yet.
Yeah.
And then what happens is she gets informed by the College of Physicians that a complaint has been lodged against her. And in this case, there's no medical error. There's no medical negligence, none of this stuff.
Which
And
is
yet,
99% of college complaints.
which is a lot of complaints are effectively around that, basically. And so her life, that she thought was sort of balanced,
And stable, yeah.
takes a spin. And everything that she's worked so hard to build starts collapsing. And then I'm not going to give the story, but what I wanted to show through Silent Oath, I like the title because the oath is something that drives doctors, right?
But we bear everything else about it with silence.
Correct. And basically every decision that we make needs to be driven by the oath that we've taken. First, do no harm. And then everything else that you know about. So the oath comes with a huge weight that we don't talk about much, which is why it's silent. This is a silent oath.
So you wrote this fiction book. You're not going to give us the ending because it is
Yes.
a gripping story.
Yes.
But it was also a commentary on the punitive nature of the College of Physicians and how complaints are dealt with in Quebec, which is not how it's dealt with in other places.
That's right.
And so, yeah, tell me about that.
That is right. There's something unique here. Can't explain why, because I don't know. But the way complaints are dealt with here in Quebec is very different from the way it's dealt with in other parts of the country and the world. For example, the burden of proving guilt or responsibility is turned on its head because
You're
a
basically
doctor
guilty until you
is
prove yourself innocent.
Yes,
Yeah.
you have to prove, as a physician, you have to prove that you have conducted yourself according to what was expected of you. That is completely opposite to what happens in front of a court of law, where you have presumption of innocence. The other thing is, once you get a complaint lodged against you and investigated by the college, you become isolated because
You're not allowed to talk to
you're not
anybody.
allowed to talk to anyone about the case and about what you're going through, because they could become witnesses. But you're not allowed to talk to the party that's lodged the complaint either.
Yeah.
Which makes no sense.
Yes. No, so you're treated like a criminal.
So you are treated worse than a criminal
Right.
because a
The
criminal has rights
yes.
that the doctor doesn't have.
Correct. And the process itself is has nothing to do with any kind of transparency or justice, or it's extremely biased. One person gets to decide
Yes.
your fate, which is just crazy to me.
And you would think that because the members of the people who sit in the various committees of the collège
Our physicians.
are physicians, you would think that they would approach it differently because, the idea is doctors need to be policed like anybody else, okay? And so you can have the government police them, or you could have doctors police themselves, which makes sense. Like if you have, say, something that happens in the police force, and, you have police investigating police. So it makes sense. You have lawyers investigating lawyers. But when it comes to physicians, here in Quebec, it's not the way you think it should be at all. And it's very different from example. For example, I'll give you, the lawyers have le barreau, right?
Yeah.
But lawyers are not afraid of le barreau.
No.
But doctors are
Yeah.
afraid of the collège.
Yeah.
Why?
Because the collège is punitive. Because there's no space for either a case where you misjudged, or medicine is not perfect. So in any case, can be complications. You can in 2020 hindsight, you can say maybe I could have done something differently. But instead of it being a learning process, if a patient files a complaint, it becomes this punitive process
Yes.
where all you do is defend yourself instead of saying, let me see if I can learn something from this.
Yes, if there is something to learn.
Yeah,
Because like
if
you
there
said,
is something to learn.
in many cases, a
Yeah.
complaint only means somebody is
Perceived
disappointed.
something differently.
That's
Yeah.
all.
Yeah.
It doesn't mean you did anything wrong.
Correct.
But somebody thinks they're disappointed with an outcome or with the way they were treated, they were spoken to or listened to or not listened to or what. It doesn't mean
Something actually happened.
something bad actually happened.
Yeah.
So you would expect fairness.
From another physician. Yeah.
Yes.
But that's not the case.
And it's not the case. And many physicians feel that way.
But it just seems like there's nothing we can do about it, which is, I find mind-boggling. Like, there has been reforms in other places, and I wonder, like, did it take a physician going to court to defend their rights? Like, what is it going to take for physicians to say, like, something needs to change in how the college does this surveillance or how they address complaints? Like, it's not normal that it continues like this, because it is, in fact, contributing to the burnout and the moral injury and all the rest of it, and the suicides.
Because there have been documented cases of physician suicide caused by investigations by the regulatory bodies.
Yeah, and that is not helping to protect the public from physicians, because you're basically destroying the practice of medicine.
Of course.
But what is it going to take to change? Did you get any feedback from the college? Did they know you wrote this book? You didn't know. They're just ignoring it. Yeah.
No.
Did you send them a copy of your book?
No. No, I didn't, because I don't think it would change anything.
No.
Unfortunately, I think the change needs to come from physicians themselves.
Advocating for ourselves.
Yes. I think physicians need to say enough. This is not right. I mean, look what happened, when was it, last year? I think it was last year, when the members of the college, you, me, everybody else, demanded
Correct.
a special assembly.
But then what happened with that? Nothing. We demanded a special assembly to get the president changed. Did they change him?
No, they didn't. The issue was not changing them. The issue was whether he was to be blamed for what he had said publicly. And what he had said publicly was...
Political.
It was political, yeah. If doctors do this, if they stop doing,
teaching and whatever,
administrative work, then this could be perceived as a breach of their professional code of conduct, which was basically threatening doctors, right? And so that led to an outrage. That led to a special general assembly or special assembly. And there was a vote on the motion of assigning blame to the president of the college. So this vote was in favor of assigning blame. Then the...
he retracted. He ended up retracting, kind of,
sort
or
of.
apologizing.
Yeah, sort of, yes. But then the, what do you call it, the board.
Yeah.
The board has the responsibility and the right to make the decision. And it chose to ignore the voice of the members of the college.
Right. And then what happened? Nothing.
Nothing.
Yeah.
So, if that doesn't show you everything that's wrong.
But that's what I mean. Like, the whole system is set. It is built to prevent physicians from collaborating and voicing. So,
Correct.
like, when you get a college complaint, you're not allowed to talk about it. So, like, how are we ever going to get together and say, like, the way college complaints are managed is managed poorly if we're from the get-go told we're not allowed to talk about our college complaints?
That's right. But I think what needs to happen is it needs to happen from the ground up, the way it happened when the doctors went to the Bell Center together and said enough. And that's what needs to happen if doctors want that.
But that would
to
require a
change.
doctor saying, I'm not ashamed of the fact that I had a college complaint. I'm willing to talk about it out loud. I'm willing to band with other people.
Yes.
Yeah.
We need to
and
talk
that's
about
hard.
it. And it is hard. But we do hard things all the time. So we need to do that.
So, but this book was kind of a step in that direction.
Exactly. Because I wanted to show that what happens to this A1 thoracic surgeon. Because somebody said, her life was too perfect. She could have more, family issues and whatnot. It would make the book more interesting. And I said, no. Because what I want to show is that she's an A1 thoracic surgeon who's got everything going for her. And yet... it almost completely destroys her too. So,
yeah, because in reality, sometimes it's not just the college complaint. You have other things going on in your marriage and your kids and and then when you compile all those stressors together,
absolutely.
That's
so what I enjoy writing about, because now this is book number 1.
Yeah. So talk about book number 2,
book number
which
2
is more likely than not.
More likely than not is coming out. It's actually just out now. officially out in mid-July. And then there's 2 other books that are in the writing
Oh my
process.
goodness. Okay.
Yes. What I like to write about is I want to show the human beyond and behind the title of doctor. To show that we're dealing with human beings to whom all sorts of things happen. Family issues, financial issues, drug addiction, trauma, regulatory problems, and everything else, and more. Because, we sort of all know, oh, doctor, you know what a doctor does. But you don't know, I mean, you do, but most people don't know
Yeah. The people behind
the
it.
person behind, behind the white coat. Now we've heard that they commit suicide at a much higher rate than the general population. And yet doctors are considered to be the most privileged profession among all. How does that compile? How does that compute? It doesn't.
No.
Right? So if it doesn't compute, it's because there's an issue there, right?
Yeah.
So why don't we look into it? So my novels are a way to talk about these things and to talk about emotions. Because at the end of the day, that's what the books are about. And a thriller, because I like to write thrillers, it's about creating emotion in the reader, right?
Suspense.
Suspense. Oh my God, what's going to happen? I can't. And also develop empathy, because when you see your character deal with terrible things, as a reader, you empathize. And so in book 1 and book 2, and 3 and 4, the protagonists are female physicians. And why is that?
Yeah. Why is that?
Well, because I wanted to be more representative of what medicine is today. 60% of medical students are female. And about
But not of surgeons.
not yet.
Not yet.
But it's changing fast. I mean, think about what it was 40 years ago, right? So it's changing very fast, and now the typical doctor is going to be a woman. So that's why I wanted to have a female protagonist. Also, I like emotions. I like women for many reasons. The emotional part, in particular, the more freedom to discuss emotions than
And
the
how
male
society,
counterparts.
portrays
Just
man.
because society does that, So it allowed me to explore it better than I would, I think, if I'd chosen a typical male surgeon. I am one, so I know. So that's another reason why I chose a female protagonist.
So more likely than not, what is the, give us the...
So this, more likely than not, is about, there's basically 2 parts to the story. The first part is a man gets thrown in jail, and it might be a case of wrongful conviction. And then fast forward a few years, there's a female resident in pathology who uses AI, part of a research project, to review forensics, and then just to explore whether the level of performance of AI to compare, etc., to improve the way, which is a very medical way of approaching things, very scientific, and then she does that, and she comes across this case, and then and AI flags a few things, and then instead of just saying, okay, this is just a research project, move on, she decides to dig because there's something that tells her there's something off,
yeah.
and then she becomes an advocate for the guy who's sent to jail.
Interesting.
And so,
but that's not based in reality.
There's parts based on reality.
Really?
Also. Yeah, I like to write based on reality.
Okay.
Because today reality is so crazy, you don't need to make anything up anymore.
Yeah, that's true.
All you want to do is
Yeah.
all you want to do is dramatize it.
Yeah.
You want to condense it. You want to make it a little bit Hollywood-esque, but the reality is reality.
So talk to me about this. So now what you spent most of your time writing, like how much time does it take to write a book?
Silent Oat took me a year.
A year of everyday writing?
No. So that's the beauty, because I write for fun, right? I'm not a professional writer. I don't make a living out of it, is what I mean. So I write when the inspiration comes. And I write when my creativity is alive. And my creativity is alive. It cannot be alive when I'm working 80 hours a week.
No, obviously not.
So when it comes, I write. And when it doesn't, I don't.
But that's pretty productive. I mean, you're saying you've got 4 books pretty much. So you've got one that's published, one about to be published, and 2 more in the pipeline.
Yes.
So you write them at the same time, or
No.
or you write one book at a time?
One book at a time.
Okay. And do you have do you have a team that helps you, or
No.
This is all self-published. Like you do this whole thing yourself.
Yeah.
It's amazing.
Yeah, I do that, and I do have an editor that helps me because they have consultants that will help me, work on the story and give me an outsider's look, But I do all of that, but it's a lot of fun.
And you're writing in English.
Yes, I write in English. I was raised in French, but I've studied in English.
And that's natural to you.
So it's also easier.
Oh yeah.
Because French is much more difficult to write
it's a much difficult language.
And speaking of which, because Silent Oath has been successful, I have gotten a lot of requests for the French version.
Oh, so you have to get it translated.
So I did. So I did translate it.
Okay. You translated
I did it but I'm going to tell you that translating a book that you wrote in English into French is not translating; it's rewriting.
Basically, because it's not the same.
It's not
you
the
can't
same
just
at all.
put it in an AI. It's not going to give you
the nuances.
Yeah, it doesn't create the same
so
effect.
anyways, I did that, and then I put it in the hands of a reviser. So somebody who's a French Canadian speaker that revised my translation because it's in French, but it needs to be international French, but still Quebec French because it happens in Montreal.
Right.
So there's a lot of nuances around that.
Yeah.
So it's translated, and now it's in the hands of a traditional editor here to see if. Because I'd like it for the book to make it to the bookshelves, to the libraries.
That's amazing. So is this your future? What is next? Like, are you going to become like a novelist and this is it?
This is what I'm doing for now.
Yeah.
But I'm still working, by the way.
I know. Yeah. You told me. Yeah.
I still work. I don't operate anymore.
Okay.
Since last September.
Okay.
So, but I like to focus now on people who seek second opinions for complex cases, people who've patients who've seen, in my field, obviously, hand and wrist surgery, people who've seen, multiple doctors and they don't know what they have, or they don't, they seek answers that they're not finding. So I see these people, but I now work I see patients 2 days a week now.
And just that, you're not operating anymore.
I don't operate anymore.
And do you miss it?
Yes and no. I miss operating because, as you know, being in the operating room is the easy part for us.
Right.
It's almost a meditation part, because you're going through your emotions and you're focused and nothing disturbs you. So that, but unfortunately you can't just do surgery. You also have to do the pre-op and the post-op. And especially if you want to do it in a very empathetic and compassionate way,
it's a lot.
It's a lot. And when you have a solo surgical practice, which I did, you know what comes with it. So do I miss it? Someday. But I didn't stop being a doctor.
No.
And I didn't stop advocating for patients and for doctors, because if I help doctors, I help patients.
Big impact there.
I think so. And it's another way to do it. And, I've been in surgery for 30 years this year.
It's crazy.
Yeah, it went this fast. And so I figured.
So did somebody take over your practice?
No, unfortunately not.
You just retired it?
Yes, I just retired the surgical practice, which was sad for me, because it was a very successful surgical practice, unique in Canada. I mean, I had people coming from all over the world to see it and to try to replicate it in other parts of the world, and they have to a certain extent, but sadly not here. But unfortunately, doctors, first of all, you need to go private to be able to do this. We don't have insurance to support our patients getting access to private care. So that's been a hurdle for doctors who are risk avert, as we know. Then you have so much instability around private practice.
Right now, especially.
Over the years, and as we've seen recently, so that doesn't help people saying, I'm going to go in that direction. So that was sad. And I felt a lot of guilt, a responsibility, because when I made that decision, I said to myself, what about all these people that need me? And that reminded me very much of what I felt when I left the public healthcare system in 2010, when I left the hospital, when I made the decision to leave the hospitals, I had 400 patients on my surgical list.
Yeah.
So that meant patients that I'd seen, diagnosed,
I needed surgery.
and they needed surgery, and they're waiting for me to do surgery. And I felt a tremendous amount of guilt when I said, what is going to happen to those people? And so I had to refer those people out to other surgeons. And to my shock, when I spoke to those patients, I'm talking 2010, and because I had to tell some of them in person,
that you wouldn't operate on
I'm
them.
not going to operate on you, and I'm really sorry about that. And they would say, why? And I said, because I'm leaving the hospital, but I'm also leaving the public sector. I'm going private. And you know what those patients said to me? We understand you, doctor. And that was a shock to me.
That is shocking.
I was expecting anger, frustration, and
Disbelief, yeah.
disbelief. How can you abandon us? No, it was like, we understand you, doctor. We support you. Mind blown.
And so talk to me about this decision to stop doing surgery. How did you come to that?
So first, it was a realization that it was 30 years of being involved in surgery,
Taking care of patients.
taking care of patients 24/7. As you know, when you're a doctor, it never leaves you. When you're on, an all-inclusive resort in Mexico, you're still a doctor.
When you're the solo practitioner in your practice.
When you're on an airplane, you're the doctor. When the flight attendant says, we need a doctor, you stand up and you go. You're always a doctor, never leaves you. So it's always on. And not just me, everyone. Right? When you're a solo surgical practitioner, you're never on vacation.
Right.
Because you're always checking your emails, you're always checking your
Patients,
messages, your phone calls, like this and that. And, you have 100 patients under your care, and then there's 99 are doing well, and one's not.
And that's your whole
What's
vacation.
the one that's on your mind?
Yeah.
That one.
Yeah.
Right. So it's heavy. And it's heavy, and I've been carrying that for 30 years without really realizing it, because,
You don't know until it's gone.
you don't know till it's gone. It's like, imagine you're walking around with 5-pound dumbbells in each hand for 30 years. Everybody has dumbbells in their hands. It's normal, right? Yeah. So you don't feel them until you put them down. And you're like, oh, my arms are so light. So there was a lot of reflection about that. There's also...
Was it in conjunction with feeling like your noveling was getting...
No, not at all.
No, so nothing.
I hadn't started.
Oh, you hadn't started yet?
No.
Okay.
No. And then there were business-related issues, human resources. When you're a small business, you are vulnerable to issues that affect HR. If you don't have...
Oh, there's an HR issue every 3 weeks. I just prepare myself for it now.
Exactly. But if you're a large company and you have a lot of employees...
It's less felt, yeah.
Yeah, but when you're a small team, those things can affect you. And then I said to myself, maybe the universe is speaking to me that this is the right time. But it was not an easy decision. But it was the right decision. And I knew, because the minute I made it, I felt lighter. Like I said, I felt guilt again and responsibility, because we doctors have what's I call captain of the ship syndrome. We have savior syndrome, and we have imposter syndrome. We have some element of all three. Captain of the ship is, I am the last one to leave the ship. And I will go down with the ship if I need to, which is completely crazy.
Yep.
Okay, but we have that.
Which is all of this is mental illness in me.
It's mental illness.
It's like
of
versions
course.
of mental illness.
It's self-harming.
Yeah.
So there's that. Imposter syndrome is, I'm not as good as other people think I am, and eventually something is going to catch up with me. And unfortunately, we all have that. And that comes from this culture of perfectionism and this and that. And then we have savior syndrome. What savior syndrome is? We need to save everyone. What that means is...
Even at our own...
Of course. But what that means is, if we save 99 and one doesn't do well, one dies, that's the one we're left with.
Yep.
And we carry that graveyard with us.
Yeah, and it's cumulative over 30 years.
Of course.
Yeah.
And then, but we don't talk about that, not enough.
No.
I don't know if today's medical students hear about that,
Nope.
but they should.
But what strikes me is that you have had the courage to make these decisions for yourself, whereas I feel like there are probably a lot of physicians who have these same feelings as you, but are just not able to take the decisions that are for their own well-being.
Oh, guaranteed. I've had so many people that I shared that decision with, and they were shocked.
Because, I mean, you're considered young to retire surgery.
Yes,
Yeah.
I'm going to be 55 this year.
Yeah.
And so people tell me, "Oh my God, you're so young." And I'm like, "Yeah, precisely. That's precisely why, because I want to enjoy other things. There's so much more to life than doing what I've been doing for the last 30 years. I've also done a lot, so doing more of it. And yeah, but all these people need you. You're right, but I'm not immortal.
Yeah.
I'm going to die.
Whether it's going to be today or in 20 years, somebody is going to need to take care of these people. Yeah.
Exactly.
Yeah.
So I sort of cured my imposter syndrome by becoming a writer. I was never trained to be a writer. I was not supposed to be a writer, and now I'm writing books. So imposter syndrome it's never completely gone, but sort of
Quieted. Yeah.
more quiet. Savior syndrome, also in the process of being cured. And captain the ship, definitely. I'll tell you a story. And I know you're going to think it's normal.
But most people don't.
But most people say it's completely insane. My father, who's the psychiatrist, passed away 10 years ago. And he didn't die abruptly. It was like a decline. So he was in the hospital doing poorly, and we knew he was going to go, became unconscious, etc. So it's just a matter of time. We knew. And then I went to see him in an evening in his hospital bed, and he was unconscious. And I took his hand, and I said to him, "You can go. We'll be okay. You can go." And that was a Monday night. And Tuesday was my operating day. So I went to my operating day as usual. At 7 a.m. I was in the clinic. I had patients lined up and everything. And I left my phone off so that I wouldn't be disturbed.
In case.
In case he passed.
Yeah. No, that's crazy.
And I operated on my patients with my phone off. When I was done with my last case, I turned on my phone, and that's when I heard
that he had passed.
And that night, I cried, and my girlfriend at the time cried with me, which to me was a shock, because nobody had ever cried with me. What's happening? But she's such an empathetic person. She felt my pain and she shared it, so she started crying with me. And she didn't know my dad at the time.
No, she felt your pain. Yeah.
Yeah. So that's how my father died. And then that was Tuesday. So the Tuesday I operated all day and etc. Then guess what I did on Wednesday?
No, you didn't go to work.
Of course.
That's crazy.
Of course I went to work.
That was your father.
I had patience.
I get it.
And
only in retrospect do you think that's not human.
It's insane.
It's insane.
But my wife, my now wife, but then she told me,
"What are you doing?
You're not going to go to work." I said, "But I have patience." And then she said, "But your father just died." And you know what I said? I said, "But there's nothing I can do about it." I said, "There's nothing I can do about it. Therefore, I need to move forward."
Yeah, but that's completely disregarding you.
Completely. But that didn't even cross my mind. I was like, I have patients who've traveled from Abitibi to see me today. I need to go. And then we planned the funeral. And the funeral was not far from here, around in the afternoon. So a ceremony with people coming, etc., etc. Guess what I did in the morning?
You went to work.
I went to work. And my patients didn't even know my father died. And so the reason I said, you might think it's normal, I'm talking to the surgeon person.
No, I can see myself doing the same thing in that situation, but I think, avec un peu de recul, with a little bit of looking at it from an outsider's, no, that's just crazy.
It's insane.
Yeah.
But my argument was,
But I've done it. I've miscarried and gone to work. I've been sick as a dog, going for IV infusions in the morning, doing a full day of surgery, going back for more IV infusions when I was diagnosed with Crohn's disease. I mean, I've done it.
but is that normal?
It's not normal. It's not normal at all. It's just that you forget what normal is sometimes when you're a doctor.
Forget what normal is.
Yeah.
Because not only are people expecting the abnormal from you,
And the superhuman, yeah.
but you forget the normal from you and your colleagues.
Yeah. But those standards, those are part of the problem. I mean,
Those are part of the problem.
Yeah.
But I've been guilty of all of these things.
Yeah. But I mean, in any other profession, a lot of people say around 50, 55, like, I want to do something else. And there's this whole notion of a second career of other
Right.
things. But in medicine, it's not viewed in a positive way. It's
Why?
viewed in a you gave up or you sold out or,
Yes,
you know.
why?
Why? We're just as creative or intelligent as any other industry where we, after 30 years of doing the same thing, have said, no, I'm ready to do something else. Like, if you were in any other profession, that would be like, yeah, career path, transition, or whatever.
Makes total sense.
But in medicine, people look at it and go like, that's weird. Why do you do that? Yeah.
Yeah, and then so when I started sharing that decision with people who knew me and friends and colleagues and whatnot, initially they'd be like, "Really? But you're so young. Aren't you going to get bored? What are you going to do?" And then I would say to them, well, I don't know. I'm going to see. Because that was the honest truth. I don't know. I'll find out.
Yeah.
Then they'll be like, you know what? I'm happy for you. I wish I could do that.
That's it. That's the thing.
That's the second reaction that I get. First is the surprise, the shock, and then they're like, oh. And now, sometimes I'm a little embarrassed because I still, meet with friends for dinners and phone conversations and whatnot. And they're asking me, how you doing? And I'm like, I'm fantastic. And I'm almost embarrassed to say. Because they're not.
Yeah.
They're not.
Yeah, because you have to be brave to take that decision. Yeah.
I guess.
But I think also part of it is
like
that we're so being a physician or being a surgeon is it's such a big part of our identity.
Absolutely.
That I find that taking that decision, it's also difficult to go back. Like if you take that decision, you're not coming back to surgery, anytime soon.
Right.
Because, after 2 or 3 years, you'd have to redo what kind of training, whatever. So it's like, it's very final, the decision. And then it's also like, you're okay giving up that part of your identity. And so I guess my question is, in preparation for that, is is it by finding a new identity, or is it by just disconnecting from that identity that you prepare yourself psychologically to be like, I'm ready to do something else?
What an amazing question. Because the identity bit is such a big one. And again, we don't talk about that.
No.
First of all, we invest so much into becoming doctors. And then we get so much out of it too. So much validation, so much, from the patients that we help, and et cetera, et cetera. But then, unfortunately, it's a profession that's very unique in a way that it absorbs everything. It leaves very little room for the rest. That's why divorce rates are so high among our colleagues, and even those that aren't divorced.
Yeah, marriages are not great.
Marriages are disasters, and whatever. And so, one of the reasons doctors can't retire, there are many reasons, but one of them is the identity part. What am I going to be? And so for the last, I want to say 5 years, I've been doing a lot of personal work on who am I? When people meet me socially, hey, introduce yourself. The natural thing is, hey, I'm JP, I'm a surgeon. Well, first I started by saying I'm not a surgeon. I just happen to practice surgery. And then people would think it's a joke, like, well, you're not a doctor? Well, I have a degree in medicine.
It's not who I am.
It's not who I am. Oh, I see what you mean. But I had to sort of work on reprogramming myself so that I would no longer be defined by what it is that I do. And then you have to sort of try to figure out who are you? If you're not what you do, who are you?
But the thing that I find so ironic about that is when you go into medicine, they select you based on you being well-rounded and having other hobbies and passions, and you know what I mean? Like everybody goes into medicine having 5 or 6 hobbies that they excel at, not just like they do on the side. And then throughout the course of your medical career, you end up
You have to give them all up.
You have to give them all up, only to find yourself at the end or at the middle of your life because saying like, I'm ready to move on to something else, but who am I? Like, when I knew exactly who I was when I was 23. Like,
yeah. And you have to give up all that is not being a doctor,
medicine,
being a surgeon, being a whatever you are, or whatever you think you are, rather. So I had to do that, and it's a bit dizzying at the beginning. When you need to figure out who is it that you are when you're not a doctor.
So I guess as a final question, what did you discover? Who are you?
I'm a father of furry kids. I'm a husband. I'm a friend. I am the son of a wonderful mother. I am a son of a late father who was wonderful, even though he was flawed, just like anybody. I'm here today discussing things with you. I am all these things, therefore I'm none of these things, right? I'm the thing that's behind. I'm the things that beyond all these things. And so then now I'm comfortable doing and being anything. It took me work to get there, but it's so liberating. You're not afraid anymore because you're no longer attached to the role that you've assumed for so long. And it's not just medicine or professional. It's also, there are people who are defined. For example, there are people who are defined by their kids. I am the mother of.
Yes, and then when the kids grow up and move away,
And then, I have nothing in life. Well, you what do you mean you have nothing in life? You are something. So let's figure out what you are. And that's work that needs to be done. And one thing that gives me hope is the young generation of the young people of today who go into medicine.
Different.
They're different.
Which is good. People always
Which is
complain
good.
about it, but I actually think it's good.
Yes, of course.
They want the work-life balance. They don't want to have to dedicate their entire life solely to medicine.
They're not going to be kamikazes. Because it's basically, as you said, we're going to select the most performing people, the best of doing all these things. Then you're going to stop doing all these things. You're going to do one thing, and then you're going to do that for the next 40 years. And somehow, don't complain, and don't eat, don't drink, don't sleep. And
neglect yourself, your family, your kids.
Don't make a mistake, because you know what's going to happen to you. We're going to hang you publicly if you make a mistake. And then we're surprised?
Yeah.
I mean, come on. So I'm optimistic about that.
Yeah.
Change is coming, and I'm optimistic about AI because AI is going to disrupt everything that we know. And I think disruption is good.
Yeah.
Is it going to be good for everybody? No.
Never is. Change is never
Nothing is good for everybody.
Yeah.
Change happens, and either you embrace it or you try to fight it, but we know that doesn't work really well. Yeah. So.
Okay, I can't thank you enough. This has been illuminating for me. There's a lot I didn't know about you, which I'm so glad to find out. And I think that a lot of what we've discussed is going to touch home with a lot of people.
I think it's going to, I hope it's going to help.
Yeah.
It certainly helps me.
Yeah.
And I hope it helps everybody, and I had fun doing it.
Okay,
so
good.
Thank you for having me.
Thank you.